Well, good morning, everybody. Thank you for joining us for our September 12th Health and Hospital Committee meeting. I'm Supervisor Ken Yeager, Chair of the committee, and joined by Supervisor Joe Simidian, the Vice Chair of the committee. And so our next item is public comment. We have one speaker, Bob Jasinski, who, if you want to come up, Bob. Good morning.
I'm a member of PFAT, Patient Family Advisory Team. I'm the chairman of the PFAT group at East Valley Clinic. And in the clinics, we have comment boxes located throughout the clinic so that patients can drop off comments on how we're doing, the good, the bad, and the ugly. And I want to read one comment from one of our patients that we picked up last month. And these are the normal comments we're getting at East Valley. And it's thanks to you folks, your effort of bringing good health care to this county into the clinics. To all, the staff is great. Staff is good. All the doctors are nice. Insight too. Very happy to be a patient here. Keep up the good work, OBGYN. And we're getting these type of comments constantly. And since Thursday is our PFAT meeting, I'm going over today to pick up all the comments. These cards are turned over to the manager of that clinic to distribute to the different groups. And we track this information. Again, thank you for all your hard work from PFAT.
Well, thank you, Bob. Appreciate that. Thank you. Scott, come on up.
Good morning, everyone. Sorry, I was Scott Largent. I was running a little bit behind. My grandma's caretaker was running late, so after this, I got to go move my car. I accidentally parked in Jeff Rosen's spot out there, but I don't really think it's going to be his spot too much longer. So I think we're eventually going to have a new DA. And I know that might sound kind of strange, but all the hard work that all my other fellow activists have been digging into the DA's office, it's just a shameful institution here in our county. It is just really bad. More evidence has come forward with Susan Bassey's case. So now video footage is starting to appear. And I believe it's Judge Pierce that is one of the judges that is in the video that was pretty much ordering the lynching of her at a courthouse. He's in there, he's filling out paperwork, he's talking to deputies. Now, why would that disappear? Why would that be not part of the exculpatory evidence? I'm very confused with that. I went through every piece of paperwork from my trial because I thought it was rigged, the Bullhorn trial. Sure enough, it is. Sections of the police report do not exist. Stuff in court was just, I mean, it's just night and day. Transcripts don't match up for what happened in court. And I do understand that it's illegal to record in a courtroom, but how can I have recordings that are different than the transcripts? That is just absolutely shameful. And I keep bringing this stuff up. And Joe, I do understand that you said that you guys just don't really have any control over the court system, but you actually do. And all these other departments, corrections, sheriff's department, probation, parole, it's all tied into our court system. And these are all funded by the county. And I really, I don't want to sound rude. You people need to wake up and start listening to the public. You've had a lot of people come in here that have been maliciously prosecuted just for doing this. They've showed up at their front door, they've hurt them, they've harassed them, they've maliciously prosecuted them, they've come up with just trumped up charges. It's ridiculous. We got another court hearing on Thursday for Susan, and I'm really wondering, where do I go with what's going on with my case? They rigged it to try to, protect the establishment. And the same thing happened in here with Victorious. He was provided videos of, you know, his day with the blow-up doll in here, okay? I watched the full footage. I didn't want what they chopped up and what his attorney gave him. During the process of that, you showed James Williams getting involved, you showed Dave Cortez getting involved, and they're sitting there ordering the hit on poor Victorious over there. And it shows the other deputies when they arrive here in the morning, why did we have more staff that day? It's all pre-planned to screw people over here in our county, and it's shameful. And we're all going to get back in here. Victorious will be back in here with his appeals. Susan's charges, I don't know what's going to happen with her. She never had a criminal record. This is disgusting, guys. Thank you. I got to go move my car.
All right, Supervisor Semedian, we need a motion to approve the consent calendar.
So moved.
Thank you. We approve that then. Item number 4 is to consider recommendations relating to specified medical staff at Santa Clara Valley Medical Center.
Good morning, Supervisor Yeager, Supervisor Semedian, honorable committee members. I'm Dr. Thomas Winsing, president of the medical staff. I'm here to present the monthly credentials report and will answer any questions you may have.
I don't believe we have any questions.
Excellent.
Would you like a motion?
I would like a motion to approve.
So moved.
Thank you. We moved on to item 5, which is to consider recommendations relating to the monthly report from our Director of the Health and Hospital System.
Yes, and good morning, Mr. Chair Yeager and Supervisor Semedian. I have a written report that indicates some of the work that our staff have been very involved with. One of the things that I wanted to make a note is we've been working very vigorously with our community clinic partners, and we have, I think, generally reached a point where they're reviewing the final draft of the agreements. It's not as a pending item, so I wanted to make sure that I flag it for you. We're going to come back to the board on September 25th with all the agreements. This is the year, if you recall, that they're making the transition from grant and performance-based to fully performance-based. So we want to make sure that you have all those details available. They're still going through that review. We've consulted with Dr. Smith, and we thought it best to have him in front of the Board of Supervisors on September 25th. We made some changes in the methodology for reimbursement for both whole person care as well as the indigent care program, PCAP and GPP points. We're still, again, working through those details. But more importantly, we've also learned quite a bit about each of the individual clinics' capacities. So what we're trying to do is be flexible to make sure that they continue on their journey towards performance and value-based. And of course, more details will be available to you and the other board members in terms of the very specifics that are negotiated in those agreements. Another part of the report, which is today's meeting, is really largely focused on the operational changes and improvements that are going on at VMC based on your direction in terms of the access as well as some of the ambulatory care changes. One of the things we wanted to highlight in my report is the ongoing successful story of the unit-based teams. And I think we have one specific one for you that our staff was so eager and happy to share with you. We have Dingat Fong as well as Nadia Zul, who are from the Sobrato Cancer Center, who are here to tell their story. And it just goes to show the engagement that's going on by our frontline staff. So if you don't mind, it'll take a couple minutes.
That'd be great. Welcome.
Thank you. Hi, good morning. My name is Nadia Zul, and I am a medical assistant and co-lead.
You want to speak up just a little louder? That'd be great.
Hi, good morning. My name is Nadia Zul, and I'm a medical assistant and co-lead in the oncology department at the Sobrato Cancer Center.
And my name is Dingan Fon. I'm an assistant nurse manager in the Cancer Center, and I'm one of the co-lead. We're here to represent the rest of our UBT team. Our UBT project was to work on reducing patient wait times. But the real value of our work is to give our patient a better care experience. We know that a diagnosis of cancer is very devastating, and we believe that no cancer patient should wait.
Our SMART goal was to decrease patient wait times from the point average of registration to rooming from our then current 20-minute average to a 15-minute average by June 30th, 2018.
The slides are not moving.
This was not part of their wait time, right?
Yeah. There you go.
Okay. Thank you. Sorry. So when we received our data, it really reflected on our month-to-month activity during our project. March was when we first tested an idea that required the registration staff to call the back office staff each time a patient registers. In April, those phone calls had become cumbersome, and the registration staff stopped calling. Back office staff were frustrated for not getting the phone calls. It seemed like our project was falling apart. Staff morale was very low. This was our valley of despair. In May, we received our first glimpse of our data that showed some gains. The positive data report re-energized staff to keep working on our project. We now believe our interventions are working. Staff were motivated. And in June, we made more operational changes that resulted even in better report.
Our biggest lesson learned was the power of data. At times, patients arrived too early for appointments. We realized there was opportunity for practice change, and we learned that positive data results inspired staff to stay the course.
Just go back for a second.
Yeah.
The issue about patients arriving too early, and then opportunity for practice change. If you could explain that a little.
So what we noted was occasionally patients show up early because a family member has to go to work or has some other errands to run. They'll drop a patient off at 8 o'clock in the morning, but their actual appointment is at 10 o'clock. So that's patient arriving too early. Opportunity for practice change came in one of our departments, in the radiation oncology department. Every Tuesday, we do have what we call on-treatment visits, that a doctor has to see a patient. A doctor has to see a patient after radiation. So sometimes it's very impacted. It's a busy day. Some patients chose not to be seen that day. They come anyways every day to the clinic. They chose to come on a Wednesday. So what we decided to do, instead of leaving that appointment open, we cancel and reschedule it on the day that they chose to see the doctor. So that helped with our numbers.
Yeah, thank you.
So our next steps will be to continue to monitor our data and to implement the use of Vocera communication device. Our tips for new teams is that the team leads must keep team motivated. They have to keep the project visible, and they must be ready to abandon ideas that don't work.
Thank you for listening and for your time.
Thank you very much.
And Mr. Chair, I think I want to recognize that here we have a perfect example of both a frontline service employee as well as a nurse working collaboratively well and focusing on those results. And of course, making it easier and convenient for our patients to see the physicians and other professionals, obviously, they need to see. So thank you very much for the work. I also want to recognize Diane Atwell, who's in the audience, who's the executive sponsor, and Barbara French, as well as Benita McLaren, who I think Benita is the one that has a perfect record on all our labor management meetings. She's always consistently been a positive champion for all of us. So thank you, Benita, for all the work you're doing across the whole health and hospital system. That concludes my report.
Well, thank you. And as I know we've said many times, the unit-based team concept really has brought great results. Everybody's been able to talk, try to figure out what the problem, getting away from the whole issue of silos. So glad that we're still proceeding with that and engaging as many of our employees as we can. So,
absolutely.
So thank you. Let me just find my agenda again. I know that Mr. Brownstein is not here, so we'll skip over B, and we'll go to 5C, which is verbal report relating to federal health policy and budget landscape. Bert, good morning.
Good morning, Mr. Chair. I have a relatively brief report this morning on federal developments. I'll start with the budget process in Washington. It's going relatively smoothly with more bipartisan cooperation than we've had in many, many years, at least amongst members of the House and the Senate. They want to get a budget package to the president's desk by the end of this month to avoid a government shutdown. That's their priority, without significant reductions in funding for healthcare programs that we care about. So that's all good news. The president, of course, remains a wild card. There are times over the last few weeks when he's...
President remains a wild card.
Remains a wild card.
I think you could say that about a lot of things.
Yes, Mr. Chair. One
That,
could.
that may be a Facebook post in the making. I just want to tell you that.
Thank you. I tried to be as careful as possible in making that characterization. He's gone back and forth on the issue of whether or not he would insist upon funding for the wall as a precondition to signing a budget. He currently is saying it can be deferred, delayed, and he's not going to shut down the government. But of course, there's an element of uncertainty as to what he will ultimately do. As far as the ACA is concerned, repeal is not in the cards for the immediate future, but there is legislation to change the ACA moving forward in the House this week. They have a bill in the House that would deal with the employer mandate penalties. They've already gotten rid of the penalties for the individual mandate. This is the mandate on employers who employ more than 50 employees. They want to defer those penalties for the employer mandate. They want to change the number of hours that an employee has to work before they're eligible for health insurance from 30 hours to 40 hours, and they also want to do something to the Cadillac tax. They want to defer implementation of that tax. It's going to probably pass the House this week, unlikely to be taken up by the Senate in a timely manner, unlikely to become law this year, but we'll read and hear about more anti-ACA actions. Meanwhile, Vice President Pence continues to say that should the Republicans retain control of the House and Senate, he anticipates they will go after the ACA again next year. This battle will be revisited. That's on the litigation front. We have this major lawsuit we've talked about in the past in Texas versus Azar. It's a direct threat to the pre-existing conditions, protections under the ACA. It's been mentioned and referenced in the Kavanaugh confirmation hearings, and Senator Manchin in West Virginia, in fact, is running TV ads totally focused on this pre-existing condition lawsuit because his opponent is the Attorney General of West Virginia, who's one of the 20 Attorney Generals who initiated this lawsuit, which would essentially gut the pre-existing condition protections in the ACA. So it's out there as an issue. The lawsuit is a serious one and something we have to track. CMS continues to try to weaken the law, but California has begun to respond. So one example of CMS Administrative Actions has been this rule involving short-term health plans, the ability to buy a policy for a short term up to 1 year that is essentially unregulated in terms of the major protections of the ACA, cheaper cost, doesn't offer you very much, not regulated plan. There's a bill on the governor's desk by Senator Hernandez, SB 910, which would make those policies illegal in California. So California continues to push back and resist these efforts to weaken the ACA. Going now to the 340B pharmaceutical discount issue, interesting development that occurred in late August. The bipartisan letter was sent to HRSA, signed by Walden and Pallone, Democrat and Republican on the House side, Alexander and Murray, Democrat and Republican on the Senate side, all four of them telling HRSA they don't anticipate taking up legislation in the immediate future until HRSA uses its existing authority to fix some of the problems of the 340B program. So it's a rare moment of bipartisan cooperation. It doesn't mean that 340B legislation in the lame duck session could not emerge, but right now it appears as if on a bipartisan basis, House and Senate are telling HRSA they're not going to act legislatively. There's also an opioid package.
Bert, just,
yes, certainly.
Just because I'm very interested in the 340B, just to pause just a little bit more about that.
Sure.
Is it because, shall we say, public hospitals were able to make a good case? I know there was a lot of criticism that it was the sort of private hospitals that were getting more money off of that program than that was meant to be. Do you have an understanding of exactly why there was a compromise? Or?
Yeah, I think, and again, it's a temporary compromise, but I think it had to do with public hospitals and many other stakeholders who argued that the kind of 340B legislative remedies that were being suggested would do a lot of damage to the healthcare delivery system. And while pharma still wants significant changes in the program, and they are very powerful in Washington, a combination of factors, and again, a rare moment of at least temporary bipartisan cooperation.
Well, it's certainly good news, at least for now, so thank you.
It is good news for now. There's also an opioid package moving through the process. The Senate is trying to put together its version. The House has already passed one. There's not a lot of money here. It's mainly changes in the way different agencies work together and the way that treatment is authorized, the way in which opioids are regulated. There are important changes in this package, but it's not the major investment of funding that most experts in the field believe is ultimately needed. That's being acted on. On Title 10, the Family Planning Grant Program, there was a bit of at least temporary positive news in that the grants were awarded, and for 7 months, the existing universe of providers have essentially been for the most part, renewed in their funding, not on a one-year basis, it's only a 7-month basis. And the reason why it's a shorter grant period, it's good that they got the money, is because this rule that many have opposed and been concerned about, including Santa Clara County, that would restrict the ability of providers who offer abortions or abortion counseling to participate in the program. This rule is still pending, and they've made it a 7-month extension because I think the administration hopes that within 7 months they'll have the rule in place and be able to change the guidelines of Title 10. But for now, the funding flows. There have been over 500,000 comments filed, and again, a lot of resistance to this rule, but and there's still a battle ahead of us on that. And the last issue, Mr. Chair, for this morning is 1115 waiver. We talked about how that's going to be a fast-track discussion in Sacramento next year. CMS on August 22nd issued guidance involving the issue of budget neutrality. This is the calculation that determines how much money a state can actually get in new federal Medicaid funds. It's always been a contentious, highly technical issue in every waiver. If you have tight budget neutrality, you can't get very much money. If it's a more relaxed standard, more money flows. And CMS has put out guidance that suggests they're going to be tightening the rules and making it harder for states like California to access funds in the new waiver. Again, highly technical issue. It's a bad signal, but there's a lot of negotiating ahead of us. And that completes my report for this morning.
Thank you. Do you have any additional comments about the bills that are on Governor Brown's desk? You mentioned briefly that
I mentioned SB 910.
Right, and which is that's with the short term.
Short term, right.
And if there were any other bills of note for us?
Not any other bills of note that I've been tracking.
Okay, thank you.
Thank you.
Supervisor Smitty?
Mr. McGowan, forgive me. I had a question, and I cannot remember now because you were going pretty lickety-split. Before 340B, you had 2 or 3 items that were specific that you referenced. Can you just call them out, and I'll see if it prompts my memory?
I talked before 340B. I talked about the regulations by CMS, short-term plans. I talked about the lawsuit Texas versus Azar. I talked about Vice President Pence and his commitment to repeal the law. I talked about the bill in the House that's going to move this week involving the employer mandate, the 30-hour to 40-hour switch. Those are the main issues I touched on.
The Texas lawsuit again is around.
So the Texas lawsuit is Texas versus Azar. 20 attorney generals who are from states that really oppose the ACA looked at what the Congress did last year with the individual mandate, and they saw the Congress eliminate the tax penalty under the individual mandate. And those 20 attorney generals said the following. Justice Roberts, when he affirmed the ACA in 2012, in that big litigation, that big challenge to the ACA, he essentially affirmed much of the ACA based upon the theory that because the Congress was taxing to make the individual mandate operational, and they have this authority to tax, all of the regulations and rules involving the individual market, involving pre-existing conditions, community rating, things that protect individuals, were therefore constitutional and were allowed to exist. So when the Congress got rid of the tax on the individual mandate, these attorney generals said, wait a second, why are we doing all this insurance regulation without a hook in the form of an operational tax? And that's the lawsuit.
And perhaps county counsel's office can help us, but do we have any sense for how long a process this might be if this thing has to make its way up through the courts? Because as I understand it, it's essentially at the trial court level now.
It is.
Yeah, okay.
But I defer to county counsel if they have any thoughts about. Hard to predict these things, but I don't know if Mr. Press has anything to say.
Well, it certainly can take years to get to the Supreme Court level. We're still at the district court level?
Yes,
not yet
district court oral arguments.
Yeah.
I'm just trying to get a sense for whether or not it's likely to have any real impact on our operations or the ACA, obviously on a national level, anytime in the next couple of years. Or doesn't sound to me like it.
I think within a couple of years there is a risk. I don't think it'll take. The Roberts, the original case came up in 2012 after the law was passed in 2010 in the challenge. So.
And what's the procedural posture? Has anyone moved for a preliminary injunction yet?
I'm not aware.
Okay. Because that would entitle them to an expedited appeal, so it slightly accelerates the process.
Thank you, Mr. Martin. Thank you, Mr. Chairman.
Thank you.
Great, thanks, Bert.
Thank you.
We'll move on to 5D, which is receive report from Behavioral Health Services Department. Welcome, Dean.
Hi. Dean Wiley, Deputy Director, Behavioral Health Services Department. Tony Tullies is not feeling well today, so she asked me to sit in. You have received our updated monthly report. A couple of things that we just want to highlight. We are working on our provider-contractor contracts. Those should be completed by October 1st. In order to assist our providers, we have scheduled a series of technical assistance trainings. These trainings are going to be conducted by Harbidge consulting firm. They're going to provide the contractors with technical assistance around how they can meet their network adequacy and their quality standards that all go along with the new mega regs regulations that are coming through. We continue our work on our electronic health record, and we are actually meeting with the NetSmart leadership this afternoon. We're meeting with them, our IS compliance, and our behavioral health leadership to discuss next steps on how we can work through the implementation with them. Once we go through that and we've determined our next steps, we'll be sure to update county leadership on our progress and what other steps will need to be taken. With that, if there are any questions regarding the report.
Just a couple quick ones. On the mobile crisis team, I know that we're not operational 24 hours, but it's a matter of providing the public with the phone number that they could call during the hours that we currently are available from 8 to 8. And I didn't know if you were thinking of releasing that phone number so that the public could call it, knowing that there might be at some point at night where nobody is answering it.
Right now, I believe we have opened up a back line for the police departments to be able to call in. I don't think we're going to release that number just yet. We're waiting. We do have it set up on our IVR system with, that's so that they can call through the call center number, and the numbers will be routed to the mobile crisis. But yeah, there would be a concern if we were to open up that number after hours and there wasn't anybody to answer the line.
Yeah, I know that certainly many people are, neighborhood organizations looking forward to having that number so that they could call it, as long as there's at least another way that they can reach the mobile crisis team. And then I noticed in the Sobering Center report that a lot of the people who are taken there report being homeless, and I didn't know what we're doing to link them to services after they leave the Sobering Center.
I don't have a specific response to that just now, but I do know that we are coordinating services with our Office of Supportive Housing to connect people that are homeless. So we do use that as a resource for those individuals that come into the Sobering Center and are homeless.
Okay. Thank you. Supervisor Medium?
Thank you. Mr. Chairman, I think you know I've been focused during my time back on the board on mental health services in the West Valley and North County for kids and their families. We've made some progress. I think there's more progress we can make. We've had some very, I think, helpful press attention on the matter, which I'll share with others. Let me ask my staff to see if we can share the coverage that I think notes some of the progress we've made, highlights some of the area where we still have challenges. I think rather than put anybody on the spot today, I'll just wait until Ms. Tully's is with us at the next meeting to pursue those. But what I want to do is sort of highlight the fact that those questions will be coming at the next meeting, and we'll communicate both with your office, Mr. Chairman, and with Ms. Tully's office prior to the next meeting to tee those up for what I hope would then be a robust conversation about progress made, but more importantly, progress we might make going forward. Okay.
All right. Thank you. So Supervisor Smitty will get a motion to approve
So moved.
5, A, B, C, and D, and we send that along. We move to 6, which is to receive a verbal report from our health officer.
Good morning, Supervisors. Sarah Cody, County Health Officer. Just a few updates, and I'm not going to give you any infectious disease updates today. It was a little challenge to myself. First, I just wanted to highlight that Assembly Bill 626 around cottage food preparation is on the governor's desk. This is a concern for our county. The health officers in California and environmental health directors have opposed it. Our concern is that should this pass and go forward, we're going to have a lot of foodborne outbreaks that we could have prevented, and we're just going to be in response mode. There's a number of different concerns about it, but that's our chief public health concern. It doesn't give us any of the tools that we need to investigate and prevent ongoing outbreaks. So we'll see what the actual impact is, but we're predicting a lot more work and difficulty keeping up, to be honest. Two really important items that I know you know about, Supervisor Yeager, but I just wanted to ensure that the committee knew about, and that is the launch of the Public Health Open Data Portal. This makes our county's health data available to anyone and everyone with an internet connection so they can have a look at it. I think this is especially important to really understand the many social determinants of health for the health outcomes that we see in our health and hospital system. We're very pleased about it. We really want everyone to take advantage of this resource that our county has invested in. Second, our work in chronic disease, we have already launched and will be highlighting tomorrow a campaign around the health harms of sugar-sweetened beverages. This is just one tool in our toolbox to prevent diabetes and obesity and other harms of added sugars, and that will have a big launch tomorrow. I think this is super, super, super important in the work that our county is doing. We've also had a lot of media around opioids, measles, and flu vaccine. Extra interest this year. I'm not exactly sure what that stems from. And finally, just a service update. As I think I mentioned before, we are now offering flu vaccines in all of the health and hospital system pharmacies. This is going to expand our reach, access, and availability for flu vaccine, which is terrific, and that's underway. And that's all I'll report on, and I'm happy to answer questions.
Well, a good report. But yeah, the Public Health Open Data Portal launch was a great success. Renee was there as well as myself, and got great press. So you had a lot of people working on it, and I see some folks that were involved in that launch. So thank you all for being there. And I don't know how much it's currently being used, but maybe there's a way to sort of track how many hits you get, just to see if we've gotten enough information out there for people to be aware of it.
Yeah, we have a number of different presentations and outreach planned. I mean, I hope everyone uses it, from curious residents to reporters to researchers, because you can download data and play with the data and see relationships that are really important.
Yeah, and I know that there is the launch with the sugary sweetened beverage event, but maybe at our next committee meeting you can talk a little bit more about that and the advertising that we're doing and the message that we're trying to
We would be
deliver.
delighted.
I'm sure everything's under wrap until tomorrow morning, but I think it'll be a good presentation.
Yes.
Thank you. Supervisor Smitty?
One quick question and then a comment. Time for a flu shot then?
It is time for a flu shot, Supervisor Smidian.
Thanks. And then on the public portal, this is an issue that I've been following, not just with respect to the recent launch, but my understanding is that we're going to try and take these public portal notions to other parts of our county organization. Yes? And the point I want to underscore here is 2 points, actually. One is, I think it's an important tool, or has the potential to be an important tool in terms of public accountability. And you know, we hold vast amounts of data here. It's not always accessible to the public in a way that really helps the public assess the effectiveness of our work. But I think as a public organization, providing that information in a way that, as you point out, allows people to work with the data, ask some what if and if then questions, I think is helpful on accountability. I also think it has the potential for, and this may be a coming challenge for our county, but I think it has the potential for people to be more engaged in providing solutions that, notwithstanding the number of folks we have on the job in any given department or agency and the caliber of those folks, you know, none of us is as smart as all of us. And so if you've given that information to the whole wide world and said, anybody got any thoughts, I think there's some potential for creative solutions and good ideas to come forth. Now, that's going to be a challenge for somebody to manage, because not all of them will be good ideas, but I do think we need to hold ourselves open to that possibility, and good for you for sort of being on the front lines of this effort. Thank you.
Thank you. We will then accept that report as well.
So moved.
And move on to item 7, which is a report from the Valley Health Plan relating to activities, opportunities, and progress.
Thank you, Chairman Yeager. First, I'd like to refer back to the prior report and point out that Valley Health Plan has already been able to access somewhat of a sneak preview version of the public health data for market planning purposes, and we greatly appreciate and endorse that effort. With that, I will focus on what is the most noteworthy aspect of this month's VHP report, which is a rather significant decline over June through July in our Medi-Cal enrollment. That is the result of a fiscal year-end reconciliation from family health plans, so it does actually represent more than one single month's activity, but it does certainly indicate a continuing downward trend.
And you want to talk a little bit more about that?
Certainly.
I'm glad you explained that there was just something else going on in that month, but is it an overall concern, or?
It definitely is an overall concern. It's something that's very difficult to pin down to a single cause quantitatively, but all of the folks that are very close to the issue on the Santa Clara Family Health Plan side and our side as well have a consensus that there are multiple causes to this. Some of them are actually good reasons, some of them are rather concerning, and some are in between. The good reasons have to do with the economy, very low unemployment rates currently, and a higher minimum wage that is increasing household incomes, and we've actually received some additional anecdotal information from the brokers we work with in Covered California that some of their clients are now going to be seeking coverage through Covered California rather than Medi-Cal because their economic situations are improved, which of course is a good thing. On the very concerning side, we do pick up a lot of anecdotal information that there is ongoing community concern about federal immigration policies that is impacting Medi-Cal enrollment, particularly for children. And in fact, we see that the composition of that decline is much heavier in the under 19 age band than other age bands. We also see that there's a pattern of normal aging out, but a lack of what we're used to in terms of replenishing inflow of new younger children and newborns into Medi-Cal, which could also tie to another thing that we're seeing in the county, which is a declining number of overall births in the county. So it's very multifaceted, and
yeah, just be a shame if people who are eligible are fearful and therefore don't sign up. And I don't know if there's anything that our Office of Equity and Social Justice, Office of Immigrant Affairs can somehow get tied into what you're saying, so as part of their message that people should still feel comfortable in signing up for Medi-Cal if they're eligible.
Yeah, we would be pleased to enter into some dialogue about that, and I'll go so far as to, I'm quite sure that Santa Clara Family Health Plan would also be quite interested in participating.
Good, thank you. Supervisor Dominion?
No questions on this item.
All right, we'll forward that on as well. And then we get to number 8, receive report from Santa Clara Valley Medical Center relating to operational, financial, quality, and safety updates.
Good morning, Supervisor Yeager, Supervisor Simidian. Just a brief update. As you know, Valley Medical Center has been going through a number of different verification surveys and certifications. I believe we've had 7 in the past 6 months. We are in the window for the Joint Commission Accreditation Survey, which happens every 3 years. So I just want to advise this committee and each of you relative to our activities around preparedness. That accreditation with Joint Commission covers all aspects of our operations, from leadership to clinical quality of care. Today, what we would like to do is, first of all, give an update from John Cookingham regarding our financials, and then I'm going to have our team provide you an update relative to our operational imperative that Supervisor Simidian asked for an update at the last Health and Hospital Committee. John? Sure.
It's always nice to report favorable kinds of financial performance. We ended the year up about $35 million favorable to the revenue budget, and we had some also a reduction in the number of, or the level of expenses compared to the budget. So the overall financial performance ended up quite favorable at the end of June compared to the budget. The The monthly billing production stuff is, again, at a high level. There's some reference to the use of implementation of computer-assisted coding, which is software that would be used to improve the accuracy of the claims and to speed up coding. When we move to ICD-10, there's more individual effort to complete the coding, and the computer-assisted coding software aids in that activity. And so we've gone through that implementation, and I think we're returning to higher levels of productivity. The monthly cash is really for all of 2017, we averaged about $62.7 million a month, and we had a low cash of $54 million and a high of 72. And when you look at 2018, our average went from 62.7 to $69.8 million a month, and we had a low of 60 and a high of 87. So our cash production has remained high, and it's about an 11% increase on a year-to-year basis. The overall outstanding accounts receivable demonstrates a consistent pattern to that. We're about at a level about 12% lower than we were a year ago. So I'd be happy to answer any questions people might have.
We're fine.
Thank you, John. So at this time, we're going to give you an update relative to our operational imperatives. As you may recall, back in early 2017, working with the County Executive's Office, we identified 4 goals or objectives for Valley Medical Center. Now, I'll just run through these real quick, which is, of course, outside healthcare costs, the non-acute medical patients within the hospital itself, and then within our psychiatric unit, inpatient unit, non-acute days, and then, of course, primary care. All of these initiatives, of course, focused on managing utilization, around improving efficiency, but also would have a significant impact from our view relative to cost, either cost savings or potential revenue generating opportunities to further create a system that remains financially viable. The other benefits, of course, which I think are really important to point out, that all of these initiatives really do focus on improving our capacity to serve the community and improving access to services that we offer at Valley Medical Center, both inpatient and outpatient. And of course, it does directly affect our ability to provide safe and quality patient care. All of this, of course, relates to our ability to provide a patient experience that I think from a public system standpoint that we would all be proud of. So at this time, I'd like to introduce George Harrell, who is our Director of Business Development and Contracting, Dr. Sanjay Karani, who is our Director of Inpatient Services, Fatima Husseini, who handles our psychiatric inpatient quality and utilization management, and of course, Denise Ramos, who handles primary care operations. We're going to first start with outside healthcare costs, which George is going to speak to.
Good morning, Supervisor Yeager, Supervisor Smidian, Dr. Smith, and members of the committee. George Harrell, Director of Business Development and Managed Care for VMC. I want to share with you our efforts towards impacting outside healthcare costs, reducing outside healthcare costs. Obviously, the benefits of this initiative are threefold. Number one really is to help us reduce payments to outside providers for the care of our patients. Number two is it allows us to better utilize existing county resources and our existing capacity. And it also improves the continuity of care and our ability to coordinate care across the system through our integrated healthcare record. If you look at where the costs are, more than 75% of those costs are facility related, primarily patient admissions through outside EDs. admissions that resulted from a specialty referral to an outside specialist, as well as other facility and ancillary charges such as skilled nursing facilities, durable medical equipment, and other services. We focused our strategies on two specific areas. One was really to increase repatriations from outside emergency departments, as well as also reducing unnecessary referrals to outside specialists. Both of these efforts really required a lot of engagement and coordination, not only among staff and our providers, but also working in close collaboration and partnership with Valley Health Plan as well. If we looked at our efforts to increase repatriations from outside emergency departments, we saw a success in this area. We were able to increase repatriations to an average of 29 per week since this program implemented. This is an increase up from 20 for the baseline period prior. This resulted in approximately 468 increased admissions to Valley Medical Center, which also translated into almost 2,400 additional patient days. And so this initiative not only helps reduce outside costs by avoiding payments to outside providers for these patients, but because a portion of those 2,400 the 468 patients are fee-for-service patients, we also experienced approximately $2.8 million in additional fee-for-service revenue. If we look at specifically HCA, non-contracted hospital system, and our results from reducing ED admissions, we saw a 27.6% decrease in costs, which translated into a $4.1 million reduction or annualized savings. And as I mentioned, we also then experienced, not just at HCA, but globally from fee-for-service patients, additional $2.8 million in revenue. There were other factors that impacted our ability to control outside healthcare costs, primarily in this instance at the Verity System hospitals. Although we saw a 5% reduction in controlling in claims volume due to contractual rate changes to market rates, we experienced a 55% increase in facility costs, which translated into a $5.9 million annualized increase.
I hear we have a plan to deal with those Verity System costs from hospitals, so we can.
We do.
Something's in the works.
So looking at our other efforts, really reducing unnecessary referrals, if we look at what the top non-emergency department institutional costs at Stanford are, number one is kidney diagnosis, cancer diagnoses. Number two is kidney disease, primarily transplantation, which is a service that we don't offer. Number three was multiple sclerosis, which includes high-cost drugs and treatments. Eye disease, as well as morbid obesity, primarily bariatric surgery, which again is another service that we don't provide. So we initially focused our efforts on cancer patient referrals. And the next slide shows that we were able to have some success in this area. Cancer-related Stanford facility costs decreased by 44%, and this translated into a $1.7 million in annualized savings. There were other factors, again, here, so that while we were able to see a 7% decrease in overall referral-related claims volume, we experienced a $3.1 million annualized increase, primarily, again, due to contractual rate adjustments to market rate. Another factor that impacted outside healthcare costs was autism services. This was a new Medi-Cal benefit where VHP became responsible for providing autism services to its Medi-Cal members in early 2016. And as a result of this, we experienced a 240% increase in utilization, which translated into a $2.7 million increase in annualized outside costs. So looking in summary, we did have some success in reducing ED admissions through repatriation. We also were able to reduce cancer referrals. This combined resulted in approximately $8.6 million in cost avoidance and or additional revenue. But the other factors that impacted outside costs, the contractual rate adjustments and the new Medi-Cal benefit, resulted in an $11.7 million increase. So going forward, we're going to continue to focus our efforts on reducing unnecessary referrals for other service lines, for other specialty service lines. We're also in the planning stages of a collaborative pilot where to better integrate our transfer center, logistics center, and the VHP utilization management services to be able to better repatriate patients from all outside hospitals. And ultimately, we're also looking at exploring potential service line development opportunities, including things such as looking at the feasibility of starting a bariatric surgery program, looking into elective joint surgery service line, as well as bringing autism services in-house. And unless there's any questions, I'm going to turn it over to my colleague.
There are questions, and I wonder if we could go back to the prior slide, please, Mr. Chairman. Just to try and set the stage, and I appreciate staff responding to my inquiries from the previous meeting. When we last met as a committee, I believe it was in August, I asked a question about the information that was provided then, and I appreciated the fact that the information was provided then about, I believe they're referred to as operational imperatives that the county executive had identified a year previously. And the goal was to address the 4 operational imperatives, as I understand it, and if I'm wrong, somebody just please correct me, to the tune of $100 million. And a big chunk of that was, of course, this first item, which is the outside healthcare costs. And I'm looking back at the memo from our last meeting that indicated that goal number 1 of the operational imperatives with respect to outside healthcare costs was to reduce the annualized rate of outside healthcare costs to no more than $50 million. The report we got in August, however, indicates, and I'm reading from the report, on a fiscal year to date basis, the costs are at the costs are at $100.6 million versus $100.0 million in the prior year. Now that seems to indicate to me that in spite of the best efforts, and I want to be clear, I'm not trying to be Mr. Doom and Gloom here, I'm trying to figure out, is this a solvable problem, and if so, what do we need to do to solve it? And that's why I'm asking these questions last time and this time. So what I'm looking at is an exhortation by the CEO to please find $50 million in savings in this area, a report a year later that says not only have we not saved $50 million, but we've actually gone up by $0.6 million, and then a report today that says, on the one hand, and that's an inside joke, on the one hand, we've managed to achieve some significant savings in some areas. On the other hand, they've been offset by significant cost increases in the others. Is that a fair characterization? So then, and Mr. Lorenz, I see you leaning in, and thank you, because I was just about to turn to you through the chair and say, so what I'm trying to figure out with all 4 segments of this report today, Mr. Chairman and members, is there really a path forward, or realistically, are we going to be, well, one of us sitting here a year from now saying, well, here we are again, and we haven't been able to put a meaningful dent in these numbers? Because I would never speak for the CEO, but my recollection is that when he brought these operational imperatives to us a year plus ago now, the exhortation to find $100 million savings was because he thought it put the enterprise at some risk. And so I'm worried about that continuing risk, and I'm trying to figure out, is this just not going to happen, or are there some things that we can do? That's why I very much appreciated the last slide, which is the summary and the next steps, but I'm, from my position as board member, I'm not very well equipped, frankly, to assess whether or not those next steps are going to have an impact or not. So, Mr. Lorenz, thanks for your patience while I teed that up. Thoughts?
Well, Supervisor, you've teed that up rather well in the sense that you've been very clear, and I think you've stated it very well, that the actual reduction to $50 million has not been achieved, and the question of whether or not is it achievable is really the nut of what you're trying to get at. And there's two things I would say, and I would never, as you said, speak for the county executive, but we know, first of all, that if we did not undertake this initiative, we would probably be in a far worse situation today than we would be otherwise. And I say that because if you look at the amount of effort and the numbers relative to the volume of patients and the dollars coming back into the system, those are real dollars to the system that frankly probably would not have been achieved unless we had this very focus and directive from the county executive, get in there and figure it out and focus on it. So that's number one. I think we're in a far better situation than we would have otherwise been if we did not undertake this directive and take it seriously. The second part of it is that, and I truly believe this, that when we look at our operations and we focus on a financial perspective, that's one way to look at it. But the other way to look at it is, what are those improvements to the system that we can achieve to improve the patient experience, to improve patient healthcare outcomes? We're a healthcare system, and there's a balance that we have to strike here. All of these initiatives, and even this initiative, does speak to our ability to manage the care of our patient better while focusing on utilization. And the staff are here and they can speak to this, but the improvements that we've achieved in the system by focusing on outside healthcare costs are significant, both from a cost and a quality standpoint and a patient experience standpoint. But it's not just about Valley Medical Center. It's about Valley Health Plan and our integrated system. So the relationship with Valley Health Plan and VMC to work together to find opportunities for improvement is further leveraged. One of the things that George had pointed out was taking our logistics center, which has been doing an outstanding job relative to managing the patient flow. We're now going to be working with Valley Health Plan at an additional level to see whether or not we can further integrate and manage utilization and hopefully save costs to Valley Health Plan in the system, but also provide better patient care outcomes. It's a long-winded answer to your question, but there's no doubt the $100 million to the $50 million was a stretch goal, and Dr. Smith was clearly sending us a message that get to work and figure it out the best you can, and I think we've done that.
Well, let me ask a couple questions and make a couple comments. One is, the first is, and I don't mean this in a flippant way, but, and actually I think, it's a fair comment on your part. It's not a great bumper sticker, but it's a fair comment, which is, it could be worse. And I think that's what you're telling us, is that but for these actions, it could and probably would be worse. So that's noteworthy. I guess the question I'm asking is, so if we keep doing what we're doing, are we going to keep getting what we've got, which is $100 million in costs? I mean, is our new goal to just hold steady, even if we do all the things that are on page 21? And I don't have an opinion about that particularly. I don't think I'm in a position to have an opinion about it. I'm just trying to figure out, as someone who's got budget responsibility here, are we, as I say, are we going to have the same conversation a year from now, because there'll be other costs that'll go up even as we're making some incremental progress on these bulleted items? Don't all rush at once. I don't so.
We're not going to hold steady. It can be done. I think the work that was done is good work, but we need to improve by orders of magnitude. A lot of that requires operational changes and trying to change the culture of both the referring staff and not the patients, but you can see that a big chunk is ER costs, which basically relates to the fact that a patient will self-select going to another facility. We can improve that by improving our access at our facility and improving our opportunities in the community where that occurs. And those are heavy lifts, but we won't stand steady, and you can count on me never forgetting these imperatives.
Thank you. I guess the one other question I have, and it's one where I really just don't know how practicable or not it is, but to the extent that the issue here is outside healthcare cost, we talk a lot about contracting out, and that's always an interesting issue, but do we have the ability to contract in to have qualified medical folks, docs, and others come and provide these services in our facility as a way to flip it? Is that a practical solution? Yes, no?
To some extent, yes. I think the bariatric surgery issue is a good opportunity. Also, the expansion of our cancer program is a good opportunity for us to keep cancer patients in our facility. We have a really world-class facility. The board's just authorized, and I think they've just installed the new linear accelerator, which is an exciting opportunity for adding the ability to service certain types of patients with certain tumors. In terms of things like transplants, we probably aren't going to be in the business ever of doing transplants, but we do need to change our referral patterns significantly.
Dr. Smith, Mr. Lorenz, whoever, is there any reason, and Mr. Chairman, I'm asking this question now at the end of one of 4 segments, but I really want it to apply to the whole conversation. Could we agendize this conversation now for next August? And I'm hoping that's easy for you, Mr. Chairman, because you'll be doing something else. He's saying it's very.
I so declare it.
Okay, thank you. Well, I mean it quite seriously, because I would like to come back in a year and say, all right, where are we again on make sure that these 4 items don't get missed, and I'm trying to have our board be helpful to the county executive's mission here, which I think is a worthy mission. And Ms. Lorenz, I want to just pick up on something you said. If I during the last 6 years, if anything's been embedded during my return to this board, it's the triple aim, and yes, it's even the triple aim plus. And so I understand that these conversations about outside healthcare costs are always going to occur, as they should and must, in the context of good medical outcomes and what kind of patient experience people are going to have. So I don't want people to misunderstand the focus on these numbers as being in any way inconsistent with the other responsibilities we have as part of our mission. But if we can bring this item back in a year and say, okay, where are we? And perhaps before then, but for sure, let's come back in a year and say, all right, it's been another year, how are we doing? Because I think, every dollar saved is another dollar we can put towards healthcare and keeping people healthy. So thank you, Mr. Chairman. If we want to roll into the next segment, that's good.
Yeah, just a couple of comments on this topic. I think it'd also be interesting to get some sort of historical trend of the rising hospital costs, because even though we might be doing better of keeping more of our patients and referring fewer to other hospitals, if costs are continuing to increase, it's always hard to sort of catch up, if you will. I mean, in some sense, you can sort of see staying steady as progress because costs have increased so much. And I just don't know how you factor that in, because I think we've done very well with all the things that we've done. But if the hospitals continue to charge more and more, I don't know how you can actually get a handle on that.
Supervisor, what we can do is look at your question a little deeper in terms of what information would be responsive to that question. And that's something we can provide to you.
Bruce, yeah.
I would just add there were, to that topic, there were a couple of points in George's report that I want to make sure aren't lost. And that's with respect to referrals to Stanford, which are the largest component of intentional outside utilization. There was, in fact, a realization over the last year on Stanford's part that we were operating under very archaic reimbursement rates for Medi-Cal that had not been reviewed for over 20 years, literally. And so that represents a unit cost impact that was completely outside of Valley Medical Center's control. And it's essentially a one-time catch-up, if you will, for exactly the phenomenon that you're referring to, Supervisor Yeager.
All right, we'll continue on.
Good morning, board members, Supervisor Yeager, Smidian, Dr. Smith. My name is Dr. Karani. I'm the medical director for inpatient medicine. I'm a hospitalist at Valley Medical Center as well, and I'll be speaking to you about the operational imperative to reduce the non-acute census at Valley Medical Center. I think this ties in actually pretty well with some of the outside healthcare costs as well. I think in order to improve repatriation and also from a quality standpoint, in order to improve access to the hospital flow as well, it requires optimization of bed capacity, which ultimately requires an improvement of length of stay and the number of non-acute patients in the hospital. So I'll be reporting to you a bit about what our non-acute working group has been doing and some of the successes we've had. You know, I've been at Valley Med for almost 20 years. I was an intern there, and the issue of non-acutes has been going on for many, many years. It's a very challenging issue. I think a solution has been very elusive just because of the nature of the problem. Many of the non-acutes essentially are patients who do not meet acute medical care, but there's barriers to discharge. Many of these patients have neurocognitive disorders such as dementia with behavioral disturbances where they're aggressive and acting out. Their families can't take care of them. Many of them are homeless, have psychosocial issues, and drug use. And VMC, as a safety net, ends up having these patients and has a very difficult time getting them back to home or to a shelter. And despite very intensive case management efforts, many skilled nursing facilities are not interested in accepting these patients. They do not want to take the risk, given how difficult these patients are. I recall a patient who I used to see while I was driving to work. He had a Huntington's chorea, which is a neurodegenerative disorder. It's chronic. It's not treatable overall. And he had wild flailing of his limbs. He was homeless. He was at the exit when I would go to VMC. Ultimately, he developed dementia. I remember seeing his camp. He was disheveled, and he ended up actually in the hospital. I remember seeing him. He was in our hospital for almost a year and a half as a non-acute patient. We could not get him anywhere. While I did my work on the CLT flow team as one of the leads, we actually, the problem became very apparent to us. In 2014, 2015, nearly 50 of our patients at VMC were non-acute out of 190 patients on medicine. Nearly a quarter of our patients were at skilled nursing facility or less. And so it became very clear to us it was affecting our flow, it was affecting quality, it's affecting our fiscal health as well. So we needed to do something different. So this working group got together. It was a multidisciplinary group, and we used several strategies. Number one was trying to be proactive. If a patient came in that was deemed non-acute in the ER, we developed a team of a case manager and a social worker that would immediately see the patient, try to facilitate discharge as best as they could. However, many of these patients would end up in the hospital because that was not possible, or they would come in because they did have an acute medical condition, ultimately become non-acute. I think the method we were using before, which was hoping that a nursing facility would take this patient or family would show up, we realized was not working. And so what we did is we took matters into our own hands and we contracted with 15 to get 15 beds at Skyline Nursing Facility. And we recognized very quickly that that was only part of the solution. These patients are very challenging. They could easily be readmitted back to the hospital. And if we sent them there, disposition is an issue. All we've done is really move the problem over to the nursing facility. So we knew we needed a clinical care team there. We also knew we needed social workers there as well to help with turnover. And so what we did is we created a post-acute care team. This is a team that has a geriatrician that's specifically trained in taking care of patients with dementia and behavioral disturbances. We had a hospitalist, also part of that team, that is trained in taking care of acute care issues. And we had a social worker and a PA. And we stationed them at the nursing facility to intensively manage these patients and be available to support these patients as well as the nursing facility. And they coordinated with us, the hospitalist, as to which patients were appropriate to go to that nursing facility. And we've had some really, really good success, which I want to go over. Sorry, I have a pointer here. I'll go back.
Doc, excuse the interruption, if
Sure.
I may. Before we go to the next part, because I'm always trying to, sort of take the nugget and make sure I capture the most important part. To grossly oversimplify a very complicated set of dynamics.
Yes.
They may not need a hospital bed in an acute care facility, but there's no place else to send them.
That's exactly right.
Okay.
That's where we're at.
Thanks. Please go for it.
So what we did is we had that post-acute care team. We contracted these nursing facility beds. And what we were able to achieve over the last 7 quarters is a decrease in the non-acute average daily census from 36 patients down to 17, which is about a 53% reduction. Remember, many of these patients can stay a year, year and a half. On average, they stay 80 to 90 days. That actually, if you do the math, is over 2,400 patient bed days we were able to save and have access for repatriation and for patients to be admitted.
Excuse the interruption again and through the chair. Let me just try and make sure I'm capturing this.
Of course.
So there are how many beds at the hospital?
I can speak for medicine. On average, we have 200, but usually the average daily census can fluctuate between 350 to 400 generally.
And how many of those folks are what I'm going to call there for the long term?
Yes. So the non-acutes can, at its high point, which I gave you the story before, there were 50 on just medicine alone. So of a census of 180 that was on medicine, we had 50. And that dropped a bit with some of the things we had done in terms of proactively recognizing these patients at the level of the ED, but we still were hovering in the 30 to 40 range, or a percentage of 10%.
And those folks, 30, 40, or 50 of them, were staying as long as 2-3 months?
2-3 months on average.
On average?
On average, but we had some who were staying over a year, as I gave you that first example. And there was no nursing, despite the case management, intense case management, there was no nursing facility that would take these patients. They were too high risk for them. Many of them would be screaming, yelling, a lot of agitation, underinsured, et cetera.
And just to make sure I understand, and I appreciate the patience, Mr. Chairman. So if I were to speak to you in layman's terms, colloquial terms, if we bumped into each other in the parking lot, I would say, you mean to tell me you've got people who don't really need to be in the hospital, but who are there nonetheless for as long as a year? You would say, yep, that's right?
I would say, yep, that's right. But as a safety net, we have no choice. We cannot put them on the street.
Fair enough. No, I'm there with you on the last piece. Please be assured. I just want to make sure I've got the full scope and extent of the challenge clear in my head.
We even brainstormed, did we want to have part of our hospital become a nursing facility, but we didn't have the real estate. We talked about creating our own nursing facility, but there's capital constraints there. So this was considered the next best solution, but I'll be honest, in trying to find a nursing facility that was willing to even take the amount we're willing to give them, many of them said no. So we had to have that support, the clinical support there at that nursing facility to deal with these patients, as well as the social worker support to make sure that turnover is occurring. Otherwise, we're just going to move the problem just one step further down.
Thank you very much. Thank you, Mr. Chairman. And thank you for letting me engage you mid-sentence sometimes, because it's helpful to me to make sure I'm not losing you the train.
My pleasure.
Please. Thank you.
So what we were able to do, what we were able to accomplish, this is a graph of what's been going on the last few quarters, and you can see once a bed contract occurred And this post-acute care team, devised of the geriatrician and the hospitalist, one of whom is behind me, Dr. Hui No. Once they came in and started managing these patients at those contracted beds, you can see a swift decline in the amount of non-acute patients at our hospital. Again, it was 50, 30, now we're down to 17. I've seen that number go down to below 10, which is absolutely astonishing. Moving the needle on this was incredibly difficult. Other things we've done, we've placed a total of 44 patients from January 18 to July of 18. If you do the math on this, and our business development team did this, and I'm using them as our reference, if we saved roughly 2,400 patient bed days, so if you calculated the amount of patients, the amount of bed days they would have spent in the hospital, but rather they went to the nursing facility, you multiplied it by the cost savings of not having them in the hospital and then subtract the cost of putting them into the nursing facility and having this PAC team, they estimated a cost avoidance of almost $4 million. And as a result of doing this from a quality standpoint, the Health Services and Advisory Group, which is a quality improvement organization for Medicare, recognized the PAC team as actually a best practice that would be recommended for other systems. Here's the length of stay that I was referring to before. On average, we were running, like you said, 2 months to 3 months as our average length of stay of these patients. And you can see the quick drop-off after roughly the second quarter of this year, once we instituted the contracted beds and the PAC team. And this led to a reduction in our length of stay, and it made us realize, well, if we are able to reduce our length of stay with our non-acutes, can we start looking at reducing the length of stay of our acute patients? And that's not as easy. You can't turn on the flames and fast food do fast food medicine, but there are other low-hanging fruit out there, and one of them is, I'll mention it here, is what we call the weekend effect, which is our discharges go down on the weekends. We don't have all the 24/7 ancillary staffing over the weekends. That results in avoidable days. So that's the other thing we're going to be doing as well. I'm looking forward to presenting that to the board at some point as well. This is one slide I'm especially proud of, is because we had that intensive management at the level of the nursing facility with our clinicians there, we were actually, in general, these are such high-risk patients, their usual readmission rate is 20%, usually come back within 30 days. Out of the 45 patients, only one patient got readmitted within 30 days. That's a readmission rate of almost 2%, which is fantastic from a quality standpoint. And that is because you had ongoing collaboration between the discharging physician and the physician who was at the back end at the nursing facility. Many times, I remember my chief once saying to me, he said that one of the most dangerous things we do is discharge a patient. We don't know what's going on with them. They get off the radar, especially to a nursing facility. That warm handoff that we did with the doc over at the nursing facility and the continued communication resulted in that extraordinary number in our readmissions. That actually helped lead an overall reduction in readmissions at Valley Medical Center that is lower than regional and California average, which is remarkable. So in summary, I think what we've done has helped reduce our non-acute patient census considerably by 50%. I don't think it was simply going out and getting beds. I think our secret sauce was making sure we did these other best practices, such as having a clinician there available that is specifically trained in taking care of these patients and having a social worker there who's available that can make sure that these patients are turning over. Of those 44 patients, by the way, 75% were able to get turned over, so we always have beds, or most of the times we have beds available to send our non-acute patients. We consider this a best practice that we want to expand and want to continue to look at ways to reduce our non-acute rate but to less than 3.5%. And as I stated before, we have a hospitalist-run initiative that I'm helping chair that's trying to reduce the length of stay of our acute patients as well, and we're specifically working on the weekend effect that I mentioned before.
Thank you.
Any questions?
Through the chair, if I may. Thank you. If we could go back to slide 25, please.
Sure.
Thanks.
Sure.
Nice to see the numbers headed in the right direction. So let's start there.
Yes.
That being said, again, I'm looking back at the report from a month ago, and the numbers here are in numbers of placements, but when we looked at this goal, non-acute medical patients, a month ago, we were reminded that the operational imperative was to reduce non-acute medical patient census to 3.5% of the total average daily census. And in looking at the graphs that were provided, or the charts that were provided there, these numbers, it indicated that non-acute hospital census, non-acute hospital census was at 5.9% for the week beginning July 1st, 2018. Does that sound about right to you?
It does vary. I mean, we usually run around, again, moving that needle was very hard. We usually run around 10%. We chose a goal of 3.5%. I think it was a very bold goal. Just getting that number, I think, down to 5 to 6% was extraordinary, but we have dropped below 3.5%. We've had a non-acute census of less than 10, which was unheard of before.
That dropping down to that lower number, though, that hasn't been something that's been sustained over time.
I think getting below 3.5% in terms of keeping it sustained there has been difficult, but staying in that, and I'll get to that. I'll get that graph right here. Here's a graph right here that you were mentioning. You're referring to. We've touched on 3.5%. Doesn't show it here, but we have. But we're still in the 5 to 6% range. We would like to get to that goal. I think maybe an expansion of beds could be a benefit for us to get to that goal, assuming that that trend continues to go down if we were to scale up.
Yeah. Even looking at the last 3 months, however, I'm looking at 6.3, 6.4, 5.9. And again, I know I'm sounding like Mr. Dark Clouds today, but part of what I'm wrestling with is if you've gotten yourself down from 10% looking to the left-hand side of this chart.
Yes.
Again, on the one hand, that was because you picked the low-hanging fruit.
Mm-hmm.
On the other hand, it sounded like that was no small accomplishment based on what you had to do to get there, which I want to acknowledge, which then makes me ask the question, and I'll look to Mr. Lorenz or to Dr. Smith or to you. So if that was the easier, I guess, decrease to achieve, is it practicable to get down to 3.5, 4, 4.5 on a sustainable basis, understanding that these numbers go up and down?
I can comment unless, Paul, you'd like to.
You can comment, but I would say yes. We believe that we can get there and we can keep it there because we still have strategies that we're employing. We're actually in the process of amending one of our contracts to add additional beds. We did an RFP. So there's more work to be done. So I believe we can.
Thanks.
And I also think we can. I think one of the barriers is when we move these patients to the nursing facility, these patients still have all these problems. And it's important for us to connect with the Office of Supportive Housing and making sure that we have an ability to get these patients back out into the community. That's a huge challenge. That we've just moved that challenge from the hospital to that nursing facility. And yes, they've had some turnover. And when you look at that initial dip, I'll be honest with you, some of it is the movement out of our hospital of those non-acutes, but eventually they do sit there for a little bit. It's not like they're churning out very quickly from there.
So if I can, and again, I'm trying to pull out of this conversation sort of the most salient points. So between now and next year when we have this conversation again, what are the one or two most important most meaningful, most effective things that you anticipate we can and should be doing in the next year to push that number down while still making sure we're mindful of quality of care?
I think, as Mr. Lorenz said, getting more beds that are contracted, because these 15 were initially a pilot, and they've shown that we've made some incredible headway. I think increasing that number, and it has been shown to help us with quality as well. We can't ignore that. It's better for the patient for us to have that clinical care team, the post-acute care team there, to prevent the readmissions back to the hospital. So on many levels, I support expanding this program. I think the X factor, though, is how do we get those patients, though, out from there to the community? And I think engaging in partnerships with, as I said, the Office of Supportive Housing and really other resources that I'm not aware of here, but that can help us get these patients back into the community is going to be key. That is not an easy solution, though.
Thank you very much.
May I
Dr.
put in my 2 cents? I think this team has done all the right things. They're making progress in all the right ways. They've got to focus on what needs to be done, and I'm really amazed by some of the efforts and some of the success they've had, particularly with the readmission issues. I would say, 3 main things that will be important a year from now is number 1, new beds externally, which is part of the reason why we're looking at O'Connor, because they do have long-term beds that are licensed. That would help considerably. If we're not successful there, we need to look at more skilled nursing facility beds, which in and of itself is not exactly a solution. It still needs, as Doctor says, to have attending staff who are monitoring and preventing readmission. So that's number 1. Number 2 is to be persistent in their current efforts to support individuals and patients as they are discharged, make sure the social workers and the teams are involved in facilitating all the care they need on the outside and doing the warm handoffs. And number 3 is to continue with the readmission efforts for acute patients, but making sure that we eliminate this weekend effect will be a big deal. So I think they've really identified what needs to be done. We're in reach, and we'll proceed ahead.
No, thank you. And wonderful that, the progress and certainly the understanding of the issues. It'd be a little interesting to know how whether California public hospitals are doing with the number of their non-acute medical patients and sort of where we rank amongst it, because obviously this is going to be a problem for any public hospital.
It is a huge challenge. One of the reasons we received the award relative to our PACT effort was the acknowledgement that this is a best practice and approach that should be adopted by other systems, particularly public hospitals, relative to the patient population.
Great, thank you. Continue on then.
Yes, I'll hand it over to Fatima. We'll be talking about non-acute psychiatric patients. I'll bring you over there. Oops, sorry.
All right. Good morning, Supervisor Yeager, Supervisor Simidian, Dr. Smith. I am Fatima Hosseini, and I am the manager over acute psychiatric services, quality improvement, and utilization review. And I'm here to report a little bit about the inpatient psychiatric segment of our hospital system and some of the challenges we've faced with our non-acute patient population. It was towards the last quarter of calendar year 2016, we started to really have a robust use of our electronic health records and our meaningful use and our decision support. And through that, we were able to identify that we had an issue, we had a concern. We started to recognize that over 70% of our patient population in inpatient psychiatry were non-acute. And that meant then for us that the implication was that these patients were not properly being served at the appropriate level of care. And so we decided to, take this on as a challenge, and we were going to do everything that we could to ensure that quality of care was being met, that patients were being properly discharged to the appropriate care setting, and that we were able to reduce our non-acute patient days. And so we were, through our initiatives, through our strategies of improvement, I'll go on to the next slide, but we were able to reduce our non-acute days, and we were able to reduce our length of stay. So if we look up here, initially we had patients in the non-acute psychiatric setting with an average daily census of about 30. We reduced our average daily census to about 15. But more importantly, we reduced our non-acute patient numbers. We went down from that 70% to about 50%. And if you can see the graph up there, it kind of demonstrates that we've had a consistent, sustained effort to reduce those numbers. How we did that was through transparency. We were extremely transparent with our reporting. We did daily reporting on our numbers. We carefully and closely monitored our patient admissions. And this would include admissions coming from the emergency room through EPS. This would include admissions coming from other acute psychiatric hospitals. And this would include admissions from IMDs, or the Institute of Mental Disease, of which we have several that we contract with, being 7th Avenue, Crestwood. We now have San Jose Behavioral Health that we sometimes receive patients from, and then we have Fremont Hospital. And so we closely monitored our patients also on the inpatient medical unit, those patients that might require an acute hospital, an acute psychiatric hospital stay, and help them, get into BAP to recover through their psychiatric crisis, and then repatriate them back to the medical unit. What we also did was we reached out to our partners, Momentum, and through 24-hour care, we were able to identify, under Margaret Obular, how we could identify those patients that are already occupying beds in our institutes, in our IMDs, and if they would be ready for discharge, so that we could transfer BAP patients, patients from Barbara Aaron's Pavilion, into those beds. And so that required a robust effort of treatment team meetings and planning, and very careful discharge planning around how we could meet the needs of the patient out in the community if they were to be discharged from the IMDs. And that would benefit our reducing our length of stay in our non-acute days, because once that bed is available, we could then transfer an appropriate BAP patient into that bed.
Could we stay on the previous slide for just a moment, please, through the
yes.
chair? Thanks. I just want to make sure I'm tracking the information. There's a black line, a red line, dark blue chart bars, the light blue bars. The black line is our target of 30%, yes?
Correct.
And the red line graph there is telling us what? Are those the non-acute patients?
That's the percentage of non-acute patients as a percent of the total average daily census at our acute facility, acute psych facility.
So if I'm looking at the operational imperative to get to that 30%, I should be looking on this chart to see how often the red line dips down close to or below the black line. Is that right?
Yes.
Okay. So just to shed my gloom and doom persona here for a minute, it looks to me like, compared or contrasted with where the numbers were a year or two ago, you've had some pretty significant and extended periods where the number really did get down to or close to your target, yes?
Mm-hmm. Correct.
All right, well, let's celebrate a little success here, okay? And then I can't help but notice, of course, that the numbers pop up again in the June, July, August timeframe there on the right-hand side of the graph. Is there a reason for that?
Yes, there's several reasons. One of the most significant reasons is that we share a population of patients with, for example, custody, and we also have patients that have very pervasive chronic mental health issues that cannot be met, or their needs cannot be met at lower levels of care, and they're waiting for Napa State Hospital placement. And Napa State Hospital had sort of closed doors on taking the acute chronically schizophrenic patient, and the need had been more so for taking forensic patients ahead of psychiatric patients. And so we were not able to transfer our Napa patients, or patients that met the criteria for a Napa hospitalization, over to Napa. So at some point, we had upwards of 11 patients waiting for Napa beds. I think now we're down to about 6 or 7, and so that number fluctuates up and down. And that speaks to our quality of care. Several of our patients that were destined for Napa at the time, that seemed to be the most appropriate placement, but through our good medical care and nursing care, we were able to put them in placements that were a lower level of care as opposed to going to Napa. So that takes a lot of time sometimes, especially if we're dealing with mental health issues. And so that kind of speaks to why we've seen a rise and a decline in those types of patients. And as well, patients that we sent to certain IMDs, perhaps they were rehospitalized. We've had, over the course of a year, maybe there's just about 2 or 3 patients that are very difficult and challenging, and they'll return to Barbara Aaron's Pavilion, and they'll be back on the Napa waiting list. So the predominant reason is related to the lack of beds at the state hospital level.
Thank you very much.
You're welcome. And so moving along, the other component of our tasks was reducing our length of stay at Barbara Allen's Pavilion. When we first took on this project in the last quarter of 2016, we saw that patients were staying well over 30 days in the locked inpatient setting. And again, this speaks to the fact that the patients were not being treated at the appropriate level of care. And for various reasons, the lack of IMD beds, the lack of Napa beds. And now as we move into this quarter of 2018, we can see that we've had a nice steady decline of reducing the average length of stay for an average Barbara Aaron's Pavilion patient. So we've decreased it almost by 50%, from 33.8 down to 16.7. And we've sustained that effort. And we've, again, and this goes back to our transparency, our daily reporting, our continuous monitoring of admissions, our continuous monitoring of readiness to discharge. I'm working with the 24-hour team to seek out beds and attempt to, build contracts with other partner organizations. Momentum opened a crisis stabilization unit. They have 8 beds, and that has relieved some of the burden for patients that might be coming into EPS. And so we've seen this nice steady decline of the average length of stay for the patients. So what we'd like to do then is to continue to reduce our average daily census of non-acute patients. And again, right now what we're facing is the crunch on the Napa State Hospital bed availability and the availability of IMD beds, but also too, Some of our patients that are non-acute, they have medical morbidities, diabetes, thyroid disease, TBI, and these are typical situations that are barriers to an admission to an IMD. But we're still working towards that goal of reducing our, our non-acute daily census to about 15 patients. We are working with Momentum and our other partners to identify, the availability of beds and transferring our Barbara Aarons Pavilion patients to those beds as soon as possible. And we, I think that one of the biggest factors that we've felt very confident about is the fact that we really identified that we had this problem, and we took a robust effort, a transparent effort to do everything that we could to face it head on and bring all of the important people to the table and continuously discuss all of our alternatives and our best options, and oftentimes on a case-by-case basis for some of our most vulnerable and challenging patients. So.
Thank you, Fatima.
Thank you.
I'm good, thank you. Except to ask, do we think that going forward we can get to the 30% number on a sustainable basis?
Yes.
And I'm not trying to get anybody to give me a money-back guarantee here that I'm going to waive next year. I'm just trying to figure out, again, what's achievable, what's not. Have we been overly ambitious in any of these goals, or are we thinking that we can get there? And it sounds like we think we have gotten there and we can get there again in the future on a sustainable basis. Yes?
Yes.
Correct.
Okay, thank you. Thank you, Ms. Chairman.
Thank you. And now I will share the remote with Denise Ramos, our Director of Primary Care Operations.
Excuse me, Denise, before you proceed, to the chair. So this is another lengthy topic. I just want to be considerate of the time of this committee and the two of you.
Time, Supervisor? We're good.
We're good? Okay. Denise, please.
I have the sensitive microphone. I just want to be sure it's on. Good morning, Supervisor Yeager, Simidian, Dr. Smith, and committee members. My name is Denise Ramos. I'm the Director of Primary Care Operations for Ambulatory, and this is my first report to you. As you know, our goal for productivity is 2.5 patients seen per hour, and we're achieving this by improving clinic efficiencies through patient-centered medical home and team-based care. This is specifically improved by provider and clinic team engagement and standardizing roles and responsibilities. Increasing total available appointments will allow increased provider-patient care time. And once we can see more patients, then we need to be sure that they come. So we need to improve our appointment utilization by reducing patient no-shows. We are working diligently to transform care through Prime, and Project 1.1 uses the use of the Staying Healthy assessment tool through Medi-Cal, which includes wellness and prevention, as well as depression and substance use assessments. And Project 1.2 has been successful. Specifically, we've been focusing on SOGI questions, sexual orientation, gender identity questions. There's a special health link bill that was custom. We actually achieved our SOGI metrics within 4 weeks and are very proud of that. And that was due to our training, which we partnered with the Office of LGBTQ Affairs. And now we will be offering a Train the Trainer program to roll out to additional departments within health and hospital system. This will also prepare for our transgender clinic service. Oh, I think I went too fast. Okay, so additional Prime metrics are the pharmacy metrics for patient safety. These were accomplished through pharmacy and an automated system. Other prime metrics that we're working on is our integration of post-acute care. And here we have a little bit of room for improvement and some specific, the transmission record metrics are pointing more towards advanced directives. So they're specific elements in the record, HealthLink record, that we will be standardizing. We also have a very tremendous team built for the complex care management of high-risk patients, and we had 5 vacancies in our complex care nurses across the primary care clinics, and now we're down to 1. So we feel pretty accomplished in hiring our team. And we also hired our assistant nurse manager who will provide leadership for that team. Here are additional prime metrics that, again, pharmacy has been working on, and they've been very successful with their quality workflows and monitoring patients, and they've actually been invited to speak at one of the local conferences. So we plan to improve clinic efficiencies through team-based care, and that multidisciplinary team includes a pharmacist, and that pharmacist is essential because after the patients have been registered, then the pharmacist sees the patients and reviews the medication list for them, which improves their compliance, it reduces risk, and improves their health outcomes as well as their overall patient experience by recognizing there's another integral part team member that's helping to take care of them. And I can give you an example. Dr. Phil Strong and I were out at Tully, and we actually saw the pharmacist doing their work, and he reconciled meds, greater than 20 meds for a patient, down to about 4 to 5 meds for the patient. And that, of course, it improved quality of life, ease of use, and cost. This shows you here regarding the med reconciliation pharmacist on site at each of our centers. About a year ago, a little over a year ago, it was very time-consuming to accomplish med reconciliation and reviewing all the list. And so now you can see the graph moved up, and with the pharmacist completing this, the provider has more time to spend with the patient. So our strategies regarding making more available appointments and utilization, we have added an overbook to all providers. We have improved coordination between Valley Connection, our call center. We use a standard scheduling access order, as well as we have standardized protocols by clinic service. We've also implemented reminder calls, automated reminder calls, live person reminder calls, and I think you would all benefit from hearing a message that says, Dr. Smith would like to see you and is looking forward to seeing you tomorrow at your 2 o'clock appointment. It's much more personalized rather than you have an appointment at 2 o'clock tomorrow at the clinic. So we're customizing that. Then we also have two-way texting. So now you get a reminder if you choose by text, and you can actually cancel the appointment by pressing a number to cancel the appointment. And then for those who pressed it unnecessarily, it asks, are you sure you want to do this? And lastly, we are finding the secret mix or the balance to how many days do we release appointments so that we can offer same-day access to our patients and do today's work today. So we're adjusting it. Initially it was at 4 days. We have a pilot at 15 days, and providers and teams are seemingly happy with the 15 days. And I think they made that decision a little bit earlier this morning. So some successes here that we should be celebrating: our cycle time from completion of registration to the printing of the after-visit summary went back in 2015 from 55 minutes to 50 minutes this summer. And our goal, we are planning to reach 45 minutes. The clinic no-show rate has significantly improved. I've been here 20 years. We were always at 20+%, and we went from 13% in 2016 to 12% this summer, or I'm sorry, year to date. And our overall average visits per hour went from 2.1 up to 2.26. And then our completed visits for patients, the total number seen has increased by 10% over the last fiscal year. Here's a trend of the different clinic sites, primary care clinic sites, and who's doing what, and how the trend has definitely shown an increase. Approximately 65% have increased, and we have two clinics that we are working more focused work with, East Valley and downtown. So one of the other successes specifically focused on our providers, our physicians, and is to use customized templates that are individualized for them. They create their favorites in HealthLink, and it speeds up their documentation process. And this supports their use and ease of use and familiarity, and shares best practices. And this is ongoing. They are one-on-one sessions. They're rather intense. So in summary, for primary care clinic access and capacity, you can see that we are moving in the right direction, and we're accomplishing some of our goals of the 2.5 per hour. And the spread will be moving from, of course, Moore Park and Sunnyvale to all. We've had our 10% growth in total visits over the past year, so we are seeing more patients. And our next steps will be continued to the provider improvement with HealthLink so that there's customization, and we will standardize team-based care within our patient-centered medical homes at our primary health care centers and continue to support our teams.
Thank you, Mr. Chairman. If we could go back to slide 41 for just a moment, please. And similar question. Thank you very much. A lot of data covered very quickly. And I keep toggling back and forth between the August data that I have and the data that you're able to provide us today, a month later. And but on this one, it's a relatively easy comparison. We had data through June the last time, and now we've got July and August data as well. So this is where we're hoping that eventually the numbers will be 2.5 across the board, according to the operational imperative. And of course, you highlighted the fact that there are a couple of places that are particularly wide of the mark, and others, I mean, as we look, there really are very few places over the course of the last year where even in any given month the number has been 2.5, notwithstanding all of those various strategies that you approached. And one of the things I appreciate about strategies is a lot of them were very practical and I could understand them, so that's but I guess my question again is, do we think we can get to 2.5? Is that a realistic goal? This is, I'm trying to, in some cases, I think, excuse me, earlier somebody said it was a stretch goal. We sometimes call them aspirational goals. We sometimes call them goals we have no chance in the world of ever reaching goals. And so I'm trying to figure out on this one again, is this something we think we can get to over time with continued work like we've got?
Yes.
Yes, this team's done a fabulous job. They've really attacked the problem from all the right perspectives. The trick here is to make sure that everybody on the clinical team is doing what they're trained to do at the right time, right service, and therefore minimize the physician's time doing things that they really don't need to do. So the clinical pharmacist intervention, the complex care treatment, the focus on registration improvement, all of that really dramatically helps, and they've been doing a great job, and I'm very confident they'll get to 2.5.
Great. Realistic expectation on how long that's likely to take?
I think by next year you'll see 2.7.
Definitely by the spring we should be seeing more trend up.
Thanks. Again, I'm not asking for people for money-back guarantees or commitments. I'm just trying to figure out if I had $5 in the office pool, where would I put it? That's probably the better way to. And I wouldn't do that, just for the record. But
I did want to make a point for the committee. The key for this imperative is not just numbers, but improving quality, improving access. So getting 10% more patients being able to get an appointment, and at the same time, as you saw, maintaining all of the quality measures, the prime measures, and improving in them is really the key function here. And so I think they've done a fabulous job. I also wanted to, since I had to step out for a moment and miss the end of the inpatient psych discussion, I wanted to give them a big pat on the back too, because cutting your non-acute patients basically by 50% is a real challenge in psych. So did a great job.
Thank you.
Through the chair, if I may, and mindful of the time, I have just one more question, and it's a place where, and I'm guessing this will come as a surprise to some of you, I can actually relate to what I think one of the challenges is, but I want to drill down a little bit. How much of a challenge on the process that Dr. Smith described going forward is that people want to see the doctor rather than somebody else on the team?
So that's an educational piece that we need to work on. I think it's generational that they want to see the doctor. It's no offense to anybody, that's the older generation. The younger generation just wants their needs met, and they will see any team member. So it's our responsibility to educate the patients that not every one of their needs is met by the physician.
Yeah, the reason I said I could relate to this, and I won't pull any of my colleagues into this conversation, but I struggle with the same phenomenon. There's only one county supervisor for the 400,000 people in the 5th Supervisorial District. Many people feel that they absolutely positively need to meet with the supervisor. Oftentimes, they will be more effectively and more quickly served if we can have one of my very capable staff people meet with them who specializes in the particular topic that brought them to our office, whether it's a healthcare issue or a roads and airports issue or whatever it may be. But, I'm guessing Supervisor Yeager has heard from constituents over the years who say, no, I need to meet with the supervisor, and you think, well, really we can probably handle this more efficiently and more effectively on your behalf and give you a good outcome if we can pull somebody into the conversation sooner rather than later. So as I say, this one resonates with me a little bit. Thank you all very much, and thank you, Dr. Smith and Ms. Lorenz and the whole team. This was very responsive to the questions I raised at the last meeting, and I'll add my exhortation that we stay on it, as you clearly all plan to do. But I think my takeaway is a lot of good work's been done, but there's more good work that's both needed and possible. And even if we can't get all the way there, it could be worse. So thank you.
Yeah, no, very good report. I know on a number of these issues I've been working on for the 10 years that I've been serving on this committee, and particularly looking at the patients per hour. What I didn't know is what is the industry best practice for how many patients per hour, and how does our goal of 2.5 fall in that range?
I don't know that I'd characterize it as industry best practice, but it sort of depends on the incentives. Probably Kaiser is a reasonable comparison, except for the fact that many Kaiser patients are in a different socioeconomic status than some of our patients, and that causes issues with transportation and other problems to get to their appointments. But Kaiser schedules 3.5 patients per hour, but they also schedule some of those appointments as video appointments in a half day. In the private sector, private doctors are incentivized by the number of visits they see, so sometimes they'll see 5 or 6 an hour, but I wouldn't advise that because they typically don't provide the same amount of quality and the same amount of support. I think in the public sector, 2.5 to 3 is a reasonably attainable number as long as you have the support with pharmacy and registration and documentation and follow-up phone calls and complex patient assessments and all of the other things that a doctor doesn't have to do, but without those, you stick those responsibilities with the doctor, it slows the doctor down considerably.
I did notice on the chart that the downtown clinic had the sort of lowest patients number, and I didn't know if there was any particular reason for that.
I'm still live, okay. So downtown clinic is not fully paneled yet. We're still recruiting more and more patients, and the providers tend to take advantage of the fact that they have maybe not booked the next appointment, so they can spend more time with that same patient. And it is skewing our numbers.
But we're trying to improve that number.
Correct, but if their panels are not full and there's no patients to be seen, you come to see me or you go to see Dr. Smith and he doesn't have anybody in the next slot, they'll continue to see into the next time frame.
Understand.
It's kind of a quality issue that they can enjoy right now. That's not our goal.
I say the more time you can spend
quality is our goal.
The more time you can spend with Dr. Smith, the better it is for all concerned.
Strangely, that's not true.
So, Supervisors Committee, we'll have a motion to approve that report.
Yes, and thanks again.
Thank you. And then item 9 is to receive the report relating to items pending before the board. And I just wanted to make a comment that I was glad to see the extra $127,000 from the State Office of AIDS to allow public health to enhance its PrEP and PEP utilization, increase mobile STD testing, and a few other things that also includes some dollars for Pride of 2019. So very glad to get those funds.
Thank you.
With that, with
need
a motion to approve
receive the report?
Yes, please.
There you go.
And then with that, we'll send that on to the board, and we will see everybody here on Wednesday, October 10th. Thank you.
Thank you, Mr. Chairman.